We're now thinking about observations we might make of hemorrhage in the trauma situation, after an accident, after a fall, after a road traffic accident, or whatever it is. And the first is we need to think about where the hemorrhage might be. So the blood's no longer in the blood vessels. Where is it gone? So the rhyme here is bleeding can be onto the floor and 4 more. So first of all, blood can leak out onto the floor. So you might be able to see blood leaking externally from the patient. And also it's very important if you're in a hospital situation is to ask the paramedics or whoever brought the patient in about the history of the bleeding. So if you say to the paramedics, okay, you've just picked Mr. Smith up from the road traffic accident, was there blood all over the seat? Was there blood in the car footwell? And they can say, no, we didn't see any blood, or yes, there was blood all over the place. So that gives us an idea of how much blood has already been lost and what we see as well. So external hemorrhage onto the floor. 4 more places, blood can classically collect in the thoracic cavity, in the peritoneal cavity, in the pelvic cavity, especially if it's associated with pelvic fractures, and of course in the long bones. Large volumes of blood can be lost from long bone fractures of the femur, the tibia, the radius, the ulna. For example, from a fractured shaft of femur, it's quite possible to lose 1 litre or 1.5 litres of blood. Very large amounts of blood. So thinking about where the blood is, that's a good observation to make. And we have to gain a history. What is the history of the trauma? What's the history of the bleeding? And is that sort of trauma often associated with large volumes of bleeding? So gain the history. And of course, remember the priority, A, B, C, D and E. The E is for exposure. So any traumatised patient, we need to expose them and look all over the body surface in case we miss any hemorrhage from somewhere. So if the patient's bleeding into their back or into the cleft in their buttocks or under a cover, then the patient might be bleeding and we could miss it. And this is very important because shock is the main cause of death after trauma. Hemorrhage is the main cause of death after trauma. So the patient bleeds, develops hypovolemic shock, and that is the main cause of death. So after trauma, the main cause of death is hemorrhage, causing shock. It doesn't get any more important than that. So how are we going to recognise it? Well, it depends on how quickly the blood is lost, really. But tachycardia is usually one of the first indicators. The pulse is going to beat faster, and it can be weaker and threadier as well. So tachycardia very often is one of the first clinical indicators. And of course, whenever you're thinking about a tachycardia, you've got to think what the patient's normal heart rate should be. So it's going to be different in a child or in an adult or an older adult. You've got to contextualise it to what is normal for that individual. So tachycardia can develop first. And roughly about the same time, you can get a skin vasoconstriction. So the peripheral blood vessels are going to vasoconstrict in order to try and maintain the blood pressure. And we see this as pallor, paleness. It can affect the skin surface, and in darker skinned people, look at the mucous membranes, particularly the lips, and see if they look hypoperfused, if there's a peripheral vasoconstriction. And another early indicator, actually a bit later, typically, but tachypnea, rapid breathing. The patient's trying hard to get more oxygen into the body. So tachycardia and vasoconstriction, probably the earliest features, followed by tachypnea. And the next one to notice is narrowed pulse pressure. Do you remember what the pulse pressure is? The pulse pressure is the difference between the systolic and the diastolic blood pressure. So if the blood pressure is 120/80, then the pulse pressure between the diastolic pressure and the systolic pressure is going to be 40 millimetres of mercury. Now, in early hemorrhage, before the systolic blood pressure starts to fall, the pulse pressure can be narrowed. So if you think about it, what that means is in early hemorrhage, the systolic blood pressure is the same, but the pulse pressure is narrowed. That means the diastolic pressure has to rise. So in early hemorrhage, there can be a rise in the diastolic blood pressure, narrowing the pulse pressure. And that can be an early indicator that the patient is bleeding somewhere. Now the reason for this is that when the blood pressure starts to drop, that's detected by the brainstem. That initiates sympathetic activity and the release of adrenaline. And the adrenaline will vasoconstrict the blood vessels, and that will raise the diastolic blood pressure. So paradoxically, one of the first blood pressure changes you might come across in hemorrhage is that the diastolic pressure is actually raised while the systolic pressure is maintained. But before that, you'd probably expect to see tachycardia, peripheral vasoconstriction and pallor, and tachypnea. But then narrowing of the pulse pressure is another indicator. And I just want to emphasise the importance of this as one of these reliable sayings, one of these trustworthy sayings. And this is it here. This is well worth memorising. Any injured patient who is cold and has tachycardia is considered to be in shock until proved otherwise. So the patient feels cool or cold because they are peripherally shut down. They will have cold hands and feet, and they may well feel cold to the touch and report that they feel cold as a symptom. So any injured patient who is cool and has tachycardia is considered to be in shock until proved otherwise. And remember that reduction in systolic blood pressure is a relatively late sign in shock. That might not occur till the patient's lost something like 30% of their blood volume. So plenty of things to look out for before the blood pressure or the systolic blood pressure actually starts to drop. So still thinking about clinical indicators, when the blood pressure starts to drop, the brain might become hypoperfused. And even actually before the blood pressure starts to drop, there seems to be something about the bleeding and the compensations that make the patient feel agitated and anxious. So you might see the patient sort of thrashing around a bit, they can become agitated. So you can get agitation, feelings of anxiety, and eventually confusion, dizziness. And patients can faint, of course. They might come round when you lie them round, but fainting is certainly possible. And the pulse. Right. Don't worry about all these clever machines we have in our hospitals to take the patient's pulse automatically for you. Take it with your fingers. Get 3 or 4 fingers in a line, put it on the patient's peripheral pulse, or put it on a central pulse. Now, when the blood pressure starts to drop, the peripheral pulses will actually go. You won't feel one. So when the blood pressure is low, the peripheral pulses go. When the blood pressure is low, the peripheral pulses go. So if the blood pressure is below 80 or 90, you might not feel a pulse in the wrist. But if you do, it will be fast, weak, and thready. And if you can't feel one in the wrist, then take a central one, take a carotid or take a femoral, and it will feel fast, weak, and thready. Fast because the patient has a tachycardia, and weak and thready because the volume of blood pumped out per cardiac contraction is going to be reduced. So the amount of blood, the volume of blood going through the arterial system per pulsation is going to be less. So the pulse is going to feel fast, weak, and thready. That's classic. So practice feeling normal pulses, and then when you feel pulses that are fast, weak, and thready, you can feel it's weak and you can feel that it's thready because you're comparing it with the normal that's already in your head. The pallor is the peripheral vasoconstriction, as is the coldness and the clamminess. Now, a lot of patients are clammy, like sweaty. Now, the reason for this is that the sympathetic innervation, which causes the peripheral vasoconstriction, also stimulates the sweat glands and gives like a cold sweat. So cold and clammy is the typical presentation. The patient feels very sweaty, but it's a cold sweat because the surface of the skin is cold. That's why we call it a cold sweat. Now, the peripheral shutdown affects the arterial system and the venous system. So there's arterial vasoconstriction to try and maintain the blood pressure, but there's also venoconstriction. Now, the venoconstriction tries to increase the pressure in the veins to increase the amount of blood going back to the heart, to increase venous return, or to increase what is called preload. So you can get venoconstriction as well. And clinically, this is very important to know about, because what you absolutely should have in any bleeding patient or anyone who is remotely at risk of becoming shocked is a large bore cannula in each arm, one in each arm. And the more peripherally shut down the patient is, the harder it's going to be to get these patients cannulated. So be aware of this and cannulate these patients with a large bore cannula, one in each arm, at an earlier stage as possible, hopefully before the peripheral venoconstriction has made your job all the more difficult. Reduced capillary refill time. Well, again, this means that there's reduced blood going into the limbs. So the classic place to do this is on the fingers. Hold the arm up, preferably above the level of the heart. Press it hard for 5 seconds, let it go, and the capillary refill time in a healthy person should be less than 2 seconds. If it's greater than 2 seconds, that is a delayed capillary refill time, and it's an indicator of hypoperfusion. Eventually, oliguria and anuria. Now, oliguria is reduced urine volumes, and anuria is no urine volumes. But of course, you don't know what was in the patient's bladder when they came in. There could be urine in their bladder that was made 2 or 3 hours ago. So if you're going to monitor this accurately to assess the renal perfusion of the patient, unfortunately you have to catheterise them and do hourly urine volumes. And you're looking for a minimum of 0.5 mils of urine per kilogram of patient's body weight per hour. So that's in excess of 30 mils for the average man, probably 30 mils for the average woman. You're looking for that amount of urine output. But you only know if they're catheterised. And of course that means they need to be on a fluid balance chart, and it needs to be accurately and strictly filled out to be any use. Eventually, of course, there can be hypoperfusion of the myocardium itself, causing cardiac dysrhythmias, and eventually ventricular fibrillation. So let's just review the sites of hemorrhage again. Now, we've mentioned the basic principle: onto the floor and 4 more. Let's look at these in slightly more detail. Hemothorax, bleeding into the pleural space between the visceral and the parietal pleural membrane. Large volumes of blood can be lost into the pleural space on either side, the right side or the left side. Peritoneal is bleeding into the peritoneal sac in the abdomen. And again, very large volumes of blood can be lost into the peritoneal cavity. We always have to make sure that a patient is not bleeding into the chest or into the abdomen. Now, there is a retroperitoneal space as well, behind the peritoneal membrane. For example, the pancreas and the kidneys are retroperitoneal. So if a kidney's bleeding, there can be a retroperitoneal bleed that won't go into the peritoneal cavity, but the patient can still lose quite large volumes of blood from that. Pelvic injuries and pelvic fractures, absolutely classical, especially pelvic fractures, for potentially torrential hemorrhage. Always have a high index of suspicion after trauma for a fractured pelvis, because make no mistake, the patient can bleed to death as a result of that. And long bone fractures we talked about, that large volumes of blood can be lost from the larger long bones. So fractured tibia, fractured femur, humerus can all be associated with very significant blood losses. Now, there's a couple I want to mention now where it's not so much the volume of blood that's important, but where that blood is. And the first I think you probably know about already, it's intracranial hemorrhage. So if there's a subdural hematoma or an extradural hematoma or an intracerebral hematoma, these are going to act as space-occupying lesions. And it's not that the patient's going to become hypovolemic because they're losing large volumes of blood, but because the space-occupying lesion is going to press on the brain and because it's going to raise intracranial pressure. So what we might notice is a reduction in Glasgow Coma Scale because of an increase in intracranial pressure. As intracranial pressure increases, Glasgow Coma Scale is going to reduce. What we might notice is lateralizing signs on the opposite side from the lesion. So if it's a right-sided lesion, the patient might develop weakness in the left arm or left leg. But the pupillary changes are on the same side as the lesion because the oculomotor nerves, the third cranial nerves, don't cross over like the other somatic nerves do. So reduction in intracranial pressure, sluggish or fixed pupil on the affected side, lateralizing signs on the opposite side. It's not the volume of blood, it's the pressure effect that that blood is exerting on the vital tissues of the brain. And the other hemorrhage in this sort of classification is cardiac tamponade, where there's bleeding within the sac around the heart, within the pericardium. And because the pericardium is fixed and fibrous, it can't expand out the way, so it's going to squash the heart inside. That's going to reduce the ability of the heart to fill with blood from the venous system, and that's going to reduce cardiac output. We mention this because it's one of the causes of shock that doesn't respond to fluid resuscitation. Now, people can bash their nose, and when they bash the nose it often bleeds. That's fair enough. An epistaxis, in fact, people can have a spontaneous epistaxis and nosebleeds. But a nosebleed or blood coming from the external auditory meatus, from the ears, can also be a sign of basal skull fracture. So well worth looking out for. And there's another feature you can get with basal skull fracture. As well as the blood leaking out, the cerebrospinal fluid can leak out. So you could get cerebrospinal fluid leaking out of the nose or out of the external auditory meatus. And of course the classical thing to do there is get your urine dipsticks, test it for sugar. If it's positive for sugar and it's a clear fluid, then that means it's cerebrospinal fluid, and that's pretty well diagnostic. In fact, I think that is diagnostic of a base of skull fracture, which has got very significant management implications. So the basic rules on the floor and 4 more: on the floor or into the thorax, abdomen, pelvis or long bones. But think a little more about it as well. Identify if your patient is bleeding into any of these cavities. If any of these cavities are changing from being actual spaces, if they're changing from being potential spaces to being actual spaces, if they're filling with blood, then that's got urgent management implications.